This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, a senior attending in the Department of Neurosurgery.
And I'm Dr. Alara, a research fellow. Today, we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026. It's a systematic review and meta-analysis titled, "Is there a way to reduce the infection associated with external ventricular shunts? A systematic review and meta-analysis of the recent bundle of care."
This is a topic that hits home for anyone who spends time in the ICU or on the wards. External ventricular drains, EVDs, are our bread and butter for managing acute hydrocephalus, TBI, and subarachnoid hemorrhages. But as we all know, they come with a tax. That tax is the risk of healthcare-associated ventriculitis. Ilara, the paper mentions some pretty staggering infection rates, doesn't it?
It really does. The authors, Ramadan and colleagues, point out that the incidence of EVD infections, or EVDI, varies wildly, anywhere from 2 to 45%. That's a massive range. It highlights how much institutional practices and diagnostic criteria differ from one hospital to the next.
45% is terrifying. Even at 10%, you're looking at significant morbidity, longer hospital stays, and, frankly, a lot of unnecessary antibiotic exposure for the patient. We've tried a million things over the years: silver catheters, antibiotic impregnated catheters, different tunneling techniques. But this paper focuses on the bundle of care approach.
Exactly. Instead of looking at a single silver bullet intervention, they looked at 17 studies, 9 of which were quasi-experimental, 6 retrospective, and 2 prospective cohorts, to see if a standardized multi-step protocol actually moves the needle. To be included in this meta-analysis, the bundle had to have at least 3 discrete preventative measures.
I like that definition. It's not just wash your hands, it's a system. What were the specific components they identified in these bundles?
It's a mix of procedural and maintenance steps. We're talking about standardized insertion protocols, the use of antimicrobial impregnated catheters, or AICs, extensive tunneling of the catheter, chlorhexidine dressings, and very strict, limited antibiotic prophylaxis. They also emphasized minimal handling of the system and specific staff training for CSF sampling.
Minimal handling is key. Every time a resident or a nurse opens that stopcock to draw a sample or measure a pressure, the door is open for staph epidermidis or staph aureus to take a trip up the line. So let's get to the meat of the results. Did the bundles work?
The numbers are actually quite impressive. The pooled risk ratio for infection when using a bundle was 0.32.
Wait, let's break that down for the residents listening. A risk ratio of 0.32 means a 68% reduction in the risk of infection compared to standard care. That is a massive effect size for a meta-analysis.
It is. They also saw a significant reduction in drain stay duration, with a mean difference of about 1.5 days. So not only are they getting infected less, but the drains are coming out sooner, which we know is a virtuous cycle. Less time for the catheter to get colonized.
Now, I saw something in the abstract that caught my eye. They found a reduction in infection risk, but they noted that it failed to significantly reduce ventriculitis specifically, or mortality. How does that work? If the infection risk is down, shouldn't ventriculitis be down?
That's where the nuance of the data comes in. The p-value for the reduction in ventriculitis was 0.0509. It's right on the edge of statistical significance. The author suggests this might be due to the heterogeneity of how ventriculitis is defined across these 17 studies. Some use strict CSF culture results, while others use a clinical plus lab definition: fever, high white cell count in the CSF, low glucose, and so on.
Ah, the classic, is it a colonization or a true ventriculitis debate? It's the bane of the neurosurgeon's existence when the ID team is involved. But even if the p-value was 0.051, for me as a clinician, a 68% drop in overall infection risk tells me that the bundle is the way to go. What about mortality and hospital stay?
That was the surprising part. There was no significant difference in mortality. The pooled risk ratio was 1.09, and the hospital stay duration didn't show a statistically significant drop either, with a p-value of 0.38.
That's an important reality check for our listeners. Just because we fix one complication, the EVD infection, doesn't mean the patient's underlying pathology goes away. If they have a massive grade 5 subarachnoid or a devastating TBI, the EVD infection is just one piece of the puzzle. Their mortality is often driven by the primary brain injury, not just the shunt.
Exactly. But as the authors argue, even if we aren't moving the needle on mortality yet, reducing the infection rate drastically reduces the complexity of care. No one wants to manage a patient with a multi-drug resistant Acinetobacter ventriculitis if they don't have to.
Absolutely.
let's talk practical application. If I'm a resident listening to this and I'm about to go to the ER to put in an EVD, what are the high-yield takeaways from this 2026 study?
First, the bundle is greater than the sum of its parts. If your hospital doesn't have a checklist, make one. The study highlights that AICs, antimicrobial impregnated catheters, are a cornerstone. If you have the choice, use them. Second, tunneling. The data suggests that longer subcutaneous tunneling helps create a physical barrier to migration of skin flora.
I've always been a big proponent of a long tunnel, at least 5 centimeters. And don't forget the prep. Chlorhexidine is mentioned as a superior dressing and prep compared to older povidone iodine protocols in many of these bundles.
And the third takeaway is the hands-off approach. The meta-analysis reinforces that standardized protocols for who can touch the drain and how the CSF is sampled make a difference. We should be treating every stopcock turn like a surgical procedure.
It's about culture change. It's moving from this is just a bedside procedure to this is a high-stakes implant. Ilara, what do the authors say about the limitations of their study?
They were very transparent about the heterogeneity. With an I-squared of 73.7% for the infection risk, the studies they looked at were quite different in their execution. Also, most of the studies were quasi-experimental or retrospective. We are still lacking a large-scale, multi-center randomized controlled trial to really solidify these bundle components.
That's the holy grail for neurosurgical critical care. But until that RCT comes along, this 2026 meta-analysis provides the strongest evidence we have that the bundle approach is the gold standard. It's hard to ignore a 68% risk reduction.
It really is. And for those interested in the deep dive, the paper includes a great breakdown of the specific bundle elements used in the most successful trials. It's a great resource for anyone looking to update their institutional protocols.
Well, this has been a great discussion. It's a reminder that sometimes the biggest advances in neurosurgery aren't a new microscope or a fancy robot, but simply doing the basics, like infection control, in a more disciplined, standardized way.
Exactly. It's about the system, not just the surgeon.
We hope this helps you in your next call shift or when you're reviewing your ICU protocols. Thank you for tuning in to the Neurosurgery Hub podcast. I'm Dr. Eris.
And I'm Dr. Ilara. We'll see you next time.
Stay sharp and keep those drains clean.